So I'm Shannon Weber with the Bay Area Perinatal Aid Center, and I'm here in conversation with Rana, who's based at Emory and is a colleague of mine from the Elimination of Mother-to-Child Transmission Stakeholders Group. Rana, do you want to tell a little bit about yourself?
Sure. Thank you for the invitation, Shannon. I'm Rana Chakraborty. I'm Medical Director of the Ponce Family and Youth Clinic here in Atlanta. A very large clinic caring for infants, children, and adolescents and young adults with HIV infection, and also providing services to women and children who are exposed, or babies who are exposed to HIV. And I also have a faculty appointment at Emory University. So that's a little about myself.
Thank you for doing this, and thanks for your patience with the technology. So my first question to you is, how is it that this news that the Mississippi baby, the cured Mississippi baby, now has virus, how does this change our conversation about cure or potential cure, particularly in infants?
Well, I think to put some perspective, obviously we're all a little bit disappointed that the virus reappeared in the baby who we thought could have potentially been cured. But there are still some questions that we need to answer, and one of them is, how was it that the virus for a pretty long period of time disappeared in this infant? And to that extent, I understand there's a protocol through the NIH. We're going to try and explore that a little bit more, not only for this baby, but maybe for other babies as well, where physicians and scientists observe the same phenomenon. So that's sort of the first part of the question. I guess the second part is, what does this mean? Well, I think not much has really changed. Around the time that we first heard about the Mississippi baby in February, around about February, March 2013, we sort of advised that patients continue taking or providing antiretroviral therapy to infected children using standard guidelines, standard national guidelines and international guidelines on antiretroviral management. And that hasn't essentially changed. I think what is important in the context of the Mississippi baby is what we can understand from the child, and what can then be extrapolated into science, and then potentially into cure and therapies. And we're still a little way off from working that out just yet. But obviously there's a very good team at the NIH, and obviously with Dr. Prasad and Liz Iriaga and others who are working quite intensely on a protocol.
Thank you for that summary. So in the meantime, here we are in clinical practice, and we have moms who can come late to care or be viremic at delivery. And this discussion around the Mississippi baby had really changed some of the counseling for the moms, if not some of the interventions that were offered for their infant. So how is it that you are counseling now in your practice, moms who come in that are potentially, quote unquote, at high risk for transmitting virus to their baby?
I think nothing has changed in that context. First and foremost, if women are pregnant in the United States, they need to have prenatal care and follow up with their provider quite regularly. If they're found to be HIV infected, it's even more important to follow on and take the necessary medications, not only for their own health, but also potentially to prevent transmission to the baby. And so that advice has not changed and won't change. And in sometimes the very unlikely and obviously very unfortunate event that a baby is found to be HIV infected, then it's again it's critical that the mum follows up in clinic for her own care and for the care of the infected child, and continues to provide the medicines until there's a cure available, or until further therapies are available, which mean we won't have to take medicines as regularly. But we're not there yet, and we may still have a little way to go before that.
Great. Thank you so much.
Okay, you're welcome. Thank you for the questions.
Yeah.